Hi, I'm Matt Binnicker, the Director of Clinical Virology and Vice Chair of Practice in the Department of Laboratory Medicine and Pathology at Mayo Clinic. Zika virus has been in the news a lot lately due to the large outbreak that's occurring in Central and South America and the significant complications that can arise from infection, including Guillain-Barré syndrome and fetal microcephaly. In this month's Hot Topic, my colleague Dr. Jana Hata will review the epidemiology of Zika virus, discuss the potential clinical outcomes of infection, and review the laboratory tests that are available to assist in the diagnosis of Zika virus infection. I hope you enjoyed this month's Hot Topic, and I want to personally thank you for allowing Mayo Clinic the ability to partner in your patient's healthcare.
Thank you for the introduction, and also to the viewers for joining us today. This Hot Topic will provide an update on the clinical manifestations of Zika virus in addition to information on treatment and prevention. We'll also review diagnostic testing options and algorithms for detection of Zika virus. I'm a current member of the College of American Pathologists Microbiology Resource Committee. As you view this presentation, consider the following important points regarding testing. How is the test going to be used in your practice? When should those tests be used? And how will the results impact patient management? Since the emergence of Zika virus in the Western Hemisphere in 2013-2014, a tremendous amount of information has been generated in the many different aspects of this pathogen, from vector preference to public health implications. In today's presentation, I will discuss the characteristics of Zika virus and its pathogenic potential, with a discussion on Zika virus and pregnancy, its emerging epidemiology, and symptoms and treatment of the disease. Appropriate use of current diagnostic methods will be discussed, and I'll conclude with potential strategies to prevent infection. Zika virus is a single-stranded RNA virus in the family Flaviviridae. Other members of this family include the yellow fever virus as well as West Nile virus. Zika is also phylogenetically closely related to St. Louis encephalitis virus. Genomic data leads us to believe that there are two major lineages of Zika, African and Asian. Strains found in the Western Hemisphere demonstrate nucleotide identity with the Asian genotype. Zika virus is most often transmitted via a mosquito vector, Aedes aegypti. Other Aedes species, such as Aedes albopictus, Aedes henselae, and others have also been implicated. Remember that Aedes aegypti and albopictus are also responsible for transmission of dengue fever and the chikungunya virus as well. Zika virus breeds in the mosquito vector, which becomes infectious after a 15-day development period and remains so for the rest of its 50-day life. Viruses spread to the next susceptible host when the mosquito takes a blood meal. We now know that there are multiple methods of Zika transmission that are not dependent upon the presence of a mosquito vector. A needle stick injury was reported in a research laboratory worker, reminding us all of the need for good laboratory practice. We will address maternal-fetal transmission in our discussion of Zika and pregnancy shortly. Transfusion-transmitted Zika virus infections were always considered a theoretical possibility, and this was confirmed in 2016 in connection with the outbreak in Brazil. In addition, asymptomatic blood donors had been identified in surveys performed in French Polynesia, Puerto Rico, Texas, and Florida. Both the U.S. Food and Drug Administration and the American Association of Blood Banks issued guidance in order to reduce the risk of Zika transmission in the U.S. blood supply. This is challenging when you consider that most donors may be asymptomatic. Due to this complicating factor, the recommendations chose to focus on methods for nucleic acid amplification-based screening of collected blood units, or utilization of pathogen inactivation technologies such as ultraviolet light or detergent treatment of blood products prior to use. Since 2008, there have been multiple confirmed reports of Zika virus by sexual transmission. Studies have demonstrated that Zika RNA can be detected in blood and semen for 6 months after the onset of symptoms or the last possible viral exposure. Women who have had possible Zika virus exposure through travel or sexual contact and do not have ongoing risk for exposure should wait at least 8 weeks from symptom onset or the last possible exposure, if they are asymptomatic, to attempt conception. Men with possible Zika virus exposure regardless of symptom status, should wait at least 6 months from symptom onset or the last possible exposure if they are asymptomatic before attempting conception. Zika virus testing is not recommended for non-pregnant persons with possible exposure who do not have symptoms of Zika virus disease, including persons who are planning to attempt conception or to assess for the risk of sexual transmission. Zika virus testing for this purpose remains of uncertain value because the current understanding of the duration and pattern of shedding of Zika virus in reproductive tissues is limited. Falsely positive tests can result in stress and expense, and falsely negative tests might provide false reassurance and lead to inadvertent fetal exposure to Zika virus. To review, Zika virus was initially isolated in 1947 in sentinel rhesus monkeys that were used for yellow fever research in Uganda. The first human infections were then reported in 1952 in Uganda and Tanzania. In terms of confirmed human infections, sporadic cases were reported in Nigeria, Indonesia, Thailand, and Gabon from the early 1970s to 2010. There was a significant epidemic on the Micronesian island of Yap in 2007. This affected nearly 2% of the population, although the infection rate might have been much higher, but there were no hospitalizations or deaths reported. In late 2013 in French Polynesia, a significantly larger epidemic was noted. Nearly 11% of the population was affected, but again, no deaths were reported. However, Zika virus was carried to Japan, France, Easter Island, and New Caledonia via travelers from French Polynesia. 114 cases of Zika with self-sustained transmission occurred in New Caledonia, secondary to exposure to a single infected traveler. In Brazil, late in 2014, a cluster of acute erythematous rash infections were noted in 18 states in Brazil. Zika virus was identified in April of 2015, and genetic studies indicated an Asian lineage of Zika was involved. The epidemic peaked in May of 2015 and affected all age groups. The pattern would be typical of spread of a new virus in a susceptible population, as there was an equal distribution of disease between both males and females. Infections were also confirmed in El Salvador, Guatemala, Colombia, Mexico, Panama, Paraguay, and Venezuela. Based on past history of viral spread, there was a major concern for transmission of Zika virus in connection with the millions of spectators estimated to attend the 2016 Summer Olympic Games in Rio de Janeiro. Athletes were warned to take precautions. Some athletes and spectators did not attend due to the perceived risk. In the end, the World Health Organization reported no confirmed cases of Zika among either athletes or visitors. In 2015, a Zika outbreak was again reported in Cape Verde in Africa, with 5,000 cases reported between September and December of that year. Here's a map of the geographic distribution of Zika virus taken from the Centers for Disease Control website, which contains an interactive map and is an excellent source of up-to-date information. This data is based on seroprevalence studies, epidemics, and tracking of individual cases, and it is continually changing. We now see cases throughout most of South and Central America, including Mexico, the Caribbean, and Puerto Rico. Also, Africa, India, and Southeast Asia. Since 2015, there have been over 5,200 cases reported in the United States. The vast majority have been in travelers returning from infected areas, but local mosquito-borne transmission has been confirmed in over 200 cases. There have been 46 confirmed cases of sexual transmission. Zika is now a nationally reportable disease. Laboratories and healthcare providers are required to report suspected cases to their local or state health departments in order to facilitate diagnosis and epidemiology. Zika virus is considered a biosafety level 2 pathogen, so it may be handled routinely at the laboratory bench with appropriate personal protective equipment. As with other flaviviruses, replication of Zika virus is thought to occur in the cytoplasm or nuclei of human host dendritic cells located near the site of the bite from the infected mosquito. The virus then spreads to the lymph nodes and bloodstream. Studies in humans, mice, and primates have indicated that the Zika virus demonstrates tropism for neural progenitor tissue, resulting in neuronal degeneration and cell death. In primate studies, after either subcutaneous or intravenous inoculation, Zika virus could be recovered from blood, saliva, urine, CSF, genital fluids, lymph nodes, heart, spleen, and GI tissue, although specific pathogenesis at the non-neural sites has not been reported. There has been an association noted between Zika virus infection and the occurrence of Guillain-Barré syndrome. Remember that GBS is an autoimmune-mediated syndrome that can occur after viral infections, including dengue, West Nile virus, and chikungunya virus. GBS is characterized by development of subacute or acute flaccid paralysis following a symptomatic disease presentation. This association was first reported in the Zika outbreak in French Polynesia with a total of 74 cases. There was a 20-fold increase in Guillain-Barré over the normal baseline prevalence, in addition to a temporal relationship to the ongoing epidemic of Zika on that island. Increases in the number of cases of GBS have also been noted in Brazil, El Salvador, and Venezuela as related to ongoing Zika virus outbreaks. Most GBS cases associated with Zika have recovered on their own, although the use of intravenous immunoglobulin, plasma exchange, and use of intensive care facilities have been necessary in some instances. One of the most disturbing aspects of Zika virus infection is its potential effect on fetal development. As we've previously discussed, Zika virus exhibits tropism for neuroprogenital cells. A 20-fold increase in reports of microcephaly in Brazilian infants was reported in October 2015, resulting in the declaration of a national health emergency. An uptick in the prevalence of microcephaly was also reported retrospectively after the French Polynesia epidemic of 2014. The greatest risk to the fetus occurs if infection takes place during the first trimester of pregnancy. The overall risk of microcephaly is estimated to be anywhere between 1 and 13%. At birth, Zika virus can be detected in amniotic fluid of microcephalic infants. However, the maternal blood may be Zika RNA negative. Congenital infection is possible in asymptomatic women. Microcephaly is associated with reduced head circumference and gestational weight, brain atrophy and calcifications, resulting in significant developmental issues and death in some cases. Ocular cataracts and auditory impairment may lead to neurodevelopmental delays. New recommendations for Zika virus testing were released by the CDC in July 2017 due to the overall declines in prevalence of Zika disease in the Americas. Current recommendations conclude that all pregnant women should be asked about Zika virus infection at each prenatal visit, regardless of symptoms. An understanding of geographic areas of concern and the time frame of potential exposure is essential in determining the risk of infection. This includes individuals with recent travel or residence in a Zika-affected area within 8 weeks before conception, or individuals with sexual contact with a person who traveled to or lives in an area with risk of Zika. For pregnant, symptomatic women with ongoing risk of Zika exposure, concurrent serologic and nucleic acid testing, also known as NAT testing, of serum and urine should be performed. A positive NAT result is confirmatory for maternal Zika infection. For asymptomatic women with ongoing risk of Zika exposure, NAT testing should be offered at the initiation of prenatal care and twice more during the duration of the pregnancy. Due to IgM persistence, Zika infection before pregnancy may confound results of serologic testing performed during pregnancy. Therefore, IgM testing is no longer recommended. This is a change from the previous recommendations. For asymptomatic pregnant women with recent possible but not ongoing exposure, such as travel, routine testing for Zika is no longer recommended due to the risk of increased false positive test results in the light of declining Zika prevalence. However, a conversation with your healthcare provider in order to assess the risk is strongly encouraged. If there is presumptive or confirmed Zika virus infection in the mother, ultrasound studies should be performed every 3 to 4 weeks in order to monitor fetal anatomy and growth. In neonates at risk, Both nucleic acid testing of serum and urine and IgM testing on serum should be performed. Testing of cord blood is not recommended. A testing algorithm for management of pregnant women is available on the CDC Zika website and should be consulted for the most up-to-date recommendations. The incubation period of Zika virus in the human host is approximately 2 to 10 days after the bite from an infected mosquito. It's very important to note that in most individuals, the disease will be mild and maybe only a few days of symptoms, and in many cases, people are completely asymptomatic. This will complicate epidemiologic follow-up of suspected cases. In the 20% of individuals who are symptomatic, you may see a mild fever, muscle or joint pain, a maculopapular rash, which is occasionally itchy, and non-suppurative conjunctivitis. Occasionally, anorexia, vomiting, diarrhea, or constipation may occur. Headache, and in some cases retroorbital pain, has been reported. You may recognize many of these symptoms as being similar to dengue fever and chikungunya virus, which are also found in the geographic areas affected by Zika. Again, this will complicate the diagnostic picture. Severe disease requiring hospitalization and death is rare. Here's a comparison of symptoms noted in Zika virus infection, dengue virus infection, and chikungunya virus infection. These diseases demonstrate a significant overlap in terms of mosquito vector transmission, geographic prevalence, and symptomology. Note that in Zika virus infection, when patients are symptomatic, characteristics such as edema of extremities, conjunctivitis, a maculopapular rash, and the absence of hemorrhage, leukopenia, and thrombocytopenia may assist in determining a diagnosis. Among these symptoms, rash and conjunctivitis is significantly more common among Zika-positive patients as compared to dengue or chikungunya. The definitive diagnosis of Zika virus infection can only be made on the basis of laboratory testing. Diagnostic testing is currently recommended for assessment of infection in individuals who are symptomatic, have a significant travel history to, or residence in a Zika-affected area. As discussed in a previous slide, all pregnant women should be asked about Zika exposure. Pregnant women should be tested based on presentation and includes pregnant women exposed via sexual partners that have lived in or traveled to a Zika risk area. Current testing methods for assessment of acute infection rely on serologic testing for presence of IgM to Zika virus and detection of Zika virus RNA in serum and urine. Due to the many similarities in symptoms, providers should also consider testing for dengue and chikungunya in symptomatic patients. Zika virus IgM may not be detectable until 4 days after the onset of symptoms and remain detectable for up to 12 weeks later. The CDC Zika IgM antibody capture enzyme-linked immunosorbent assay, otherwise known as the Zika MAC ELISA test, is used in qualified public health and reference laboratories in the United States for the qualitative detection of Zika virus IgM antibodies in serum or cerebrospinal fluid collected from persons meeting the clinical and epidemiologic criteria for suspected Zika virus disease. Confirmation of any non-negative IgM result will require the use of a plaque reduction assay to detect specific neutralizing antibody to Zika virus. The PRNT assay is only performed at CDC or certain designated state laboratories. It should be noted that with current assays, cross-reactivity with other flaviviruses leading to false positive results is an issue. Not only does this apply to previous infections with viruses such as St. Louis encephalitis or West Nile virus, but Zika serologic false positives could also occur in individuals who have received vaccinations for other flaviviruses such as yellow fever or Japanese encephalitis. Therefore, the plaque reduction neutralization test, or PRNT test, measures Zika virus-specific neutralizing antibody titers and should be performed to rule out false positive ELISA results due to other flaviviruses. Nucleic acid detection by the reverse transcriptase polymerase chain reaction targeting the non-structural protein 5 genomic region is the primary means of definitive diagnosis of Zika. RT-PCR, or NAT testing, for Zika virus is extremely sensitive and specific. However, due to the short period of viremia, serum and urine samples must be collected within 14 days of the onset of symptoms. If possible, urine should always be collected with a patient-matched serum specimen. If the specimen can be collected within 14 days of illness onset, the use of PCR will nullify the cross-reactivity issues noted with serologic testing for Zika. If a PCR result is positive, that is considered confirmatory and no additional testing is required. If molecular testing for Zika is negative, this does not rule out the possibility of Zika virus infection, and serological testing for Zika IgM is recommended. There are now a number of molecular tests from different manufacturers that have obtained emergency use authorization from the US FDA for Zika diagnosis. Generally speaking, testing can be performed on serum, plasma, or urine. Here are some factors to consider if your laboratory needs to pursue Zika virus testing. Both serological and molecular testing for Zika virus is available from reference laboratories and through certain state departments of health. It is very important to have a conversation with your testing laboratory prior to specimen submission to determine if testing is available and what types of samples are acceptable, especially for molecular testing. The availability of testing and specimen requirements may vary, so ask first. If you are submitting specimens for testing, you will need to supply the following information. It is essential to know when samples were collected in relationship to symptoms and any pertinent travel, residence, and medical history, including pregnancy status, in order to determine the most appropriate testing. Algorithms to guide when and how Zika testing should be performed are available at www.cdc.gov/Zika. The treatment for Zika virus infection in symptomatic individuals consists of supportive care only and are mainly comprised of rest and fluids. This may include aspirin, acetaminophen, or other non-steroidal anti-inflammatory agents for joint pain and headache. Testing to rule out dengue fever should be performed before use of these agents due to the possibility of hemorrhage. Antihistamines are helpful for itchy rash. No antiviral agents have demonstrated activity against Zika. There are no specific recommendations for treatment of Zika virus in pregnant women or in microcephalic infants. Individuals infected with Zika should avoid mosquito exposure in order to reduce the risk of local transmission. The possibility of sexual transmission should also be considered and condom use encouraged. Will we see a Zika vaccine? It's very possible. An amazing amount of research in this area in the last several years has given us the following possibilities for vaccine development. Based on mouse and primate studies, a focus on development of Zika neutralizing antibody in the host is believed to be effective in preventing infection. Towards that end, approaches based on development of a DNA vaccine expressing Zika premembrane and envelope protein sequences, an adenovirus vector using those same protein sequences, or an inactivated purified Zika virus are being actively investigated. All of these approaches have resulted in phase 1 clinical trials in order to prove vaccine safety and immunogenicity. If efficacy is demonstrated, additional trials will continue. The major challenge with Zika vaccine development will be a formulation that is sufficiently immunogenic, has acceptable side effects after administration, and is effective and safe for use in pregnant women. Although we've started to see an overall decreased prevalence of infection, local transmission of Zika virus has occurred in Florida, Texas, and Hawaii. Most Zika cases have been directly associated with travel to an affected area, primarily South America or the Caribbean. As the vast majority of cases have been travel-related, be an informed traveler before you go. Recommendations will change, so consult the CDC travel page for the most up-to-date information. Most importantly, if you are pregnant, if at all possible, you should consider postponing travel to areas with reported Zika virus transmission. If you must travel, avoidance of mosquito bites and use of repellent will not only protect against Zika, but also exposure to dengue, chikungunya, and malaria. Women who are trying to become pregnant should discuss the risk of Zika with their medical provider before they travel. If you do become ill after travel to an endemic area, see your medical provider without delay and provide a specific travel history. If you are ill, protect yourself against mosquito bites in order to prevent the possibility of viral transmission to others. Clean up the immediate environment by removing debris and sources of standing water where mosquitoes breed. Apply insecticides such as DEET or use permethrin-treated clothing. And use barriers such as long pants, long sleeves, and window screens. To summarize today's presentation, Zika virus has rapidly emerged around the world, including the United States. Most cases are in association with a human-mosquito-human cycle. However, there is a risk of sexual, laboratory, and blood transfusion-transmitted infections. Of greatest concern is the possibility of Zika transmission in pregnant women due to the potentially devastating neurotrophic effects of Zika infection in the developing fetus. Most infections in adults are asymptomatic or mild, consisting of fever, arthralgia, headache, and rash. Symptoms can be confused with dengue or chikungunya. Conjunctivitis, extremity edema, and rash are more likely to occur in association with Zika virus infection. Only supportive treatment is recommended at this time. Rarely, more severe cases of Zika can result in manifestations such as Guillain-Barré syndrome. Zika virus infection in expectant women has been positively linked to microcephaly and other fetal brain abnormalities. The overall risk of microcephaly if infection occurs during the first trimester is estimated to be between 1 and 13%. If you are traveling to an area in which Zika has been reported, avoid mosquito bites. If you are ill, avoid mosquito bites in order to prevent transmission to others. Finally, there are specific travel recommendations that have been issued by the CDC in response to this epidemic. Women who are pregnant are currently advised against travel to areas where Zika transmission is ongoing. These recommendations will change over time, so consult the CDC travel page for the most up-to-date information. This concludes today's presentation. Thank you for your attention.